Midwifery is a really rewarding career, and I'm so glad that I am a midwife. Special moments for me, I think any moment when you know that you've made a positive impact on a family. So working in the preterm birth clinic, it's really nice working as a multidisciplinary team.
When you come into this world, surely a midwife was there beyond the trimesters and postpartum. The love they show in the childbirth is extraordinary and leaves the positive prints on the mind of the pregnant and the newborn for the rest of the life. Here we will talk with the midwives from around the world and will explore the midwifery dimensions. Today we are going to talk with Naomi Carlisle, who is a preterm birth researcher. Hi Naomi, could you tell us a bit about yourself?
So my name is Naomi, and I'm a midwife who specialises in preterm birth research. So I work at King's College Hospital, King's College London University and St Thomas's Hospital in London, and I'm what's called a clinical academic, which means that I work clinically some of the time as a midwife, and then I also undertake research for the rest of the time. So I'm currently undertaking a PhD fellowship funded by the National Institute for Health Research, which means I work on my PhD 4 days a week and I work clinically 1 day a week. And at the moment, because of COVID-19, I'm currently working on the labour ward, but hopefully when COVID is a little bit more settled, I'll be moving back into the preterm birth clinic at St Thomas's Hospital, which is led by Professor Shannon.
What drove you to specialize in preterm birth? Why did you not pursue any other area of healthcare?
Yeah, I think there are loads of really interesting areas in midwifery. To be honest, I kind of landed into preterm birth. I completed my master's degree and I was looking for a job as a research midwife. And I applied for one at St Thomas's Hospital, and I ended up being put in the team that was led by Professor Shannon. And he runs the prematurity clinic and has a lot of experience in this area. So I kind of landed in this team, but I just really enjoyed it. And I remember thinking that before I joined this team, I didn't really know a lot about preterm birth. The hospital that I'd worked in previously didn't really have clear preterm birth pathways. And there was quite a lot of gaps in my knowledge. And I suddenly realised that actually across the whole of England, quite a lot of hospitals had these gaps when it came to preterm birth care. So I felt like working in this team, I had this sort of growth to, ensure that all hospitals across England were all offering sort of similar standard of care to women. So I felt that by working in this area that I could help improve the care for all women across the UK. And it also helped that I just really enjoyed the team that I work with. We're a team of obstetricians, midwives. It's very multidisciplinary. It's a really good working environment. And I think having great colleagues just really makes you enjoy your work a lot more.
Could you tell us a bit about your previous work in this area?
Yeah, so the team that I work in developed something called the Quip app. And it's available to download for free on Apple or Android. And there's also a website version, which is www.quip.org. And the good thing about the Quip app is that it enables you to predict a woman's risk of having a spontaneous preterm delivery. And it does this by the app asks you the woman's medical history and the results of her clinical tests, so her fetal fibronectin result and or her cervical length measurement. And it inputs it all together and it gives you a risk score for the woman's risk of delivery before clinically important timeframes. So within 1 week, 2 weeks, 4 weeks, and before certain gestations. So you can use this app on women if they are symptomatic of preterm labour. So it might be that they've arrived with symptoms that makes you think that they might be having their baby early, so abdominal pain, that sort of thing. And it can also be used on asymptomatic women, so women who don't have any symptoms of preterm labour, but perhaps they have a risk factor, which means that they're more likely to have their baby early. So it might be that they've had previous cervical surgery in the past or previous preterm birth. So we know that this app works. It's been validated. It's had numerous studies published about it. It's got over 1,800 women in the asymptomatic arm of the study, and 1,000 women in the symptomatic arm. It's registered with the MHRA as a Class 1 medical device. So we know that this app works. However, I was coordinating a trial with Dr. Ellie Watson, and we were looking at if, when clinicians use this app, does it help them reduce unnecessary triages and unnecessary transfers? So even if we know that the app works, does it work in practice? Does it help doctors and midwives do their job effectively? And this was called the EQUIP study, and the results of it should be published later this year. But I spent about 3 years working on this trial, and I really enjoyed it. It was a great team. I learned a lot, but I also found it really interesting because it highlighted some things to me. So, for example, part of the study, I was involved in interviewing women who had threatened preterm labour. So they'd arrived at hospital with the symptoms of preterm labour. And when I was talking to all these women, all of them described their symptoms of threatened preterm labour as period pain. So obviously a woman, medically can't have periods when they're pregnant, and she's not experiencing period pain, but that was the reference point that women referred their pain to. And I think that's really important because it's quite a woman-centred term, and quite often when we're talking about threatened preterm labour, we talk about abdominal pain or back pain, and it's all very medical-driven terms. And I think when these interviews highlight to me that when we're talking to women, we should really try and use the same language that they use. It's important to listen to women and their symptoms and to use the same reference points that women are using. And I think this helps us as clinicians. It helps us know what women are thinking, and it also helps us know that we're on the same wavelength as women as we should be. So that was really important to me. And I think as midwives, we're quite good at using sort of woman-centered terminology when perhaps obstetrically we're not. So I think this kind of highlights again the importance of having midwives involved in this sort of research. Secondly, I think this study really highlighted to me the importance of not over-medicalising women and their babies. So midwives traditionally are really good advocates of this, but we know that in preterm birth, this isn't necessarily happening. So in the UK, we know that about 70% of women who present with symptoms of threatened preterm labour actually give birth at term. And we know that more than 95% of women who present with these symptoms of preterm labour don't deliver within 14 days of presentation. However, the majority of women who do come into hospital with these symptoms are often admitted. And once they're admitted in the hospital, they're often given interventions like steroids. And while antenatal steroids are really life-saving drugs for the women who need them, for women who don't need them, we know that after 7 days of having these steroids, they don't provide any benefit to the baby. And even just with one course of steroids, we know that after 7 days, these babies have lower birth weights, smaller head circumferences, shorter lengths, and any sort of positive effect is lost. So I think it's really important that we don't give these interventions as a blanket approach to everyone. We really should only be giving them to women who need them. And that's where it's really important to know who is likely to deliver imminently and who's not. And I think that's why the EQUIP app is really good, but also just the idea of assessing a woman holistically. So looking at everything about her, and I think midwives traditionally are really good at this, and that's something we should try not to lose as midwives. I think it's quite easy to think that, preterm birth is an area which is outside our midwifery range. It's not a normal area, and we should leave it to our obstetric colleagues. But I would definitely argue that as midwives, there's a role for us in pregnancies which are diverting from the normal, and women should not receive any midwifery care just because they suddenly have a higher risk pregnancy. It should be that there's still a role for midwifery there. So I'm a really big advocate of that. When we were doing this trial, we realised that quite a lot of hospitals didn't really know how to use the QUIP app, didn't really know how to manage these women who are arriving in threatened preterm labour. So myself, Dr. Ellie Watson and Professor Shannon applied for some money to develop a toolkit to help sites implement the QUIP app at their unit. And we were successful, and we developed this toolkit last year, and it's now been published and it's available for free. And you can access that at www.bapham.org/quip. And it's got some really good resources there to help your hospital site implement the QUIP app. So it's got frequently asked questions, it's got patient information leaflets, it's got audit tools, stickers, it's got loads of different things. And hopefully people will find that really helpful when they want to try and improve the care pathways for women who arrive in threatened preterm labour at their hospital.
As you are currently pursuing a PhD, could you elaborate on your current research thesis?
Yeah, so I'm currently doing a PhD fellowship funded by the National Institute for Health Research. So my PhD is looking at how we implement the preterm birth pathway across England. So why is this important? So it's important because currently around about 8% of babies are born preterm in the UK, which is about 60,000 babies per year. And the Department of Health is very keen to reduce the preterm birth rate from 8% to 6% by 2025. We know that preterm birth is a really stressful event for parents and the wider family unit. And often babies who are born early do not survive. And those that do survive often have short and long-term health problems. And preterm birth has been estimated as costing public services £3.4 billion annually. So it's a really big problem which needs addressing. So trying to help meet this aim of reducing the preterm birth rate, the NHS England has published a document called Saving Babies' Lives Care Bundle. And in that bundle, it recommends a best practice care pathway called the Preterm Birth Surveillance Pathway. So currently in the UK, you might have a woman who has risk factors for preterm birth. So she might have had cervical surgery or a previous preterm birth or a previous late miscarriage. And some of these women, when they first arrive at the hospital saying that they're pregnant, some of these women will be referred to a special preterm birth clinic. Some women will have additional care with an obstetrician, and some women will just have midwifery care. And that completely depends on where you live. So the care is not standardised across the UK. But this NHS England document aims to standardise that care. So what it would like to happen is that every single woman, when she's in England, when she goes to a hospital and says that she's pregnant, she's risk assessed for her risk of preterm birth. And if she's determined to be at high or intermediate risk of preterm birth, she should then be referred to a preterm birth clinic. And if she's low risk, then she can continue with normal antenatal care. And if she's referred to one of these preterm birth clinics, she should then be offered screening and interventions if necessary to try and prevent her having her baby early. So with this document, we know that hospitals should be implementing this pathway in 2020. Obviously, we've had COVID, which has sort of been thrown into the mix as well. But this is the first time that a pathway has been recommended for women at risk of preterm birth. And it's quite a significant service change for a lot of hospitals. We know that the majority of hospitals in the UK don't have a preterm birth clinic at the moment. We know there's only around about 40 preterm birth clinics in the UK. So what my PhD aims to do is to research how, why, for whom, to what extent, and in what context the preterm birth pathway is implemented. And it's going to do that through what's called a realist evaluation. And a realist evaluation is important because instead of just asking what works, it asks what works for whom. And it's expecting that what works in a large tertiary unit, such as St Thomas's Hospital in London, probably isn't going to work in a small district general hospital, which doesn't have a specialist in preterm birth care. So the aim of the study is just to find out how can we help implement this pathway effectively? What is going to work for these different hospitals? And I hope at the end to produce a set of recommendations for how we can ensure national coverage to try and ensure that there aren't variations in care and that all women across the UK are getting access to the correct care that they require.
Could you tell us a memorable moment where you felt proud to be a midwife?
Yeah, I mean, I think midwifery is a really rewarding career, and I'm so glad that I am a midwife. But special moments for me, I think any moment when you know that you've made a positive impact on a family. So working in the preterm birth clinic, it's really nice working as a multidisciplinary team, and seeing a woman and her partner finally have a baby after so many losses of preterm births or late miscarriages. That's a really nice moment. I think it's also really nice just working in a multidisciplinary team, and knowing that you're making positive steps for midwifery in quite an obstetric dominated world. Research is still very obstetric dominated, so knowing that you're trying to make a pathway for midwives who are undertaking research, I think is really important to me. And I think that I got the PhD fellowship, which I'm currently on. It was quite a competitive scheme to get that money, and I felt really proud that I had managed to get the funding, but also that I was, again, kind of making steps towards making midwifery research just more prominent and something which midwives can think, yeah, I can do research, and that's a career pathway that I can do. And I think at the moment that career pathway perhaps still isn't there. And lastly, I would say the QUIP app toolkit, which we developed, that was recently recommended by NHS England in their guidance. And I was really proud that something that we'd developed has now been recommended nationally, and hopefully that means that more and more women and babies across England are going to be receiving gold standard care. And I was really proud of that moment that we, as a multidisciplinary team, all worked together to produce that.